Welcome everyone, I am Dr. Birhanu. Today's presentation will be on common behavioral disorders in children October 2022. The followings are the outline of the presentation. Thank you to be with me and don't forget to subscribe and like the channel to get other related videos. The followings are the outline of the presentation. Objective. Definition of behavioral disorder. Categorization of behavioral problem. Assessment of behavioral disorders. Common behavioral disorder. Recommendation. The reference I used for the presentation is from Kliegman, Nelson Textbook of Pediatrics 21 edition chapters 32 to 54 and 2021, up to date. And some contents are taken from Kaplan and Sadok's Pocket Handbook of Clinical Psychiatry 6th edition. After the session you would able to know about common behavioral disorders in childhood. Types. Causes. Diagnostic criteria with Diagnostic and Statistical Manual 5. Management of selected childhood behavioral disorders. Introduction to behavioral disorder. When is a behavioral disorder considered in children? A young person is said to have a behavioral disorder if she or she is different from expected. Not doing what adults want to do. Cannot adjust to a complex environment. Unable to behave in the socially acceptable way. Classification of behavioral disorder are based on age and nature of the disorder and categorized into spontaneous responsive, non-spontaneous responsive. Also classified according to the settings. Behavioral disorder. The most common behavioral disorders are, respectively from highest to lowest prevalence are, language problems, behavior or emotional disorders, attention deficit hyperactivity disorder, learning disabilities. Less common and more disabling disorders are intellectual disabilities, account for 1 to 2%. Autism spectrum disorders in 1 of 59 children, cerebral palsy and related motor impairments account for 0.3% and hearing impairment. Causes of behavioral disorder are classified as 1. Heredity. 2. Environmental causes, and examples of environmental causes are poor economy, mass media, changing lifestyle and urbanization. The third cause is physical and mentally sick or handicapped conditions like unhealthy relationship, lack of discipline, change in moral standards and value. The 11 mental health action signs are: the first one is feeling very sad or withdrawn for more than 2 weeks. Second is seriously trying to harm or kill him or herself, or making plans to do so. The third is sudden overwhelming fear for no reason, sometimes with a racing heart or fast breathing. Fourth, involvement in many fights, using a weapon, or wanting to badly hurt others. Severe out of control behavior that can hurt him or herself or others. Not eating, throwing up, or using laxatives to make him or herself lose weight. Intense worries or fears that get in the way of your daily activities. Extreme difficulty in concentrating or staying still that puts you in physical danger or causes school failure. Repeated use of drugs or alcohol. Severe mood swings that cause problems in relationships. And the 11th is drastic changes in his or herself behavior or personality. Rapid psychosocial assessment. Screening interview for taking a rapid psychosocial history. Parent interview is abbreviated as HEDSAS, which is a mnemonic for home. How well does the family get along with each other? Education. How well does your child do in school? Activities. What does your child like to do? Does your child do anything that has you really concerned? How does your child get along with peers? Drugs. Has your child used drugs or alcohol? Sexuality. Are there any issues regarding sexuality or sexual activity that are of concern to you? Suicide. Depression. Has your child ever been treated for an emotional problem? Has your child ever intentionally tried to hurt him or herself or made threats to others? Screening tool for behavioral disorder. Psychiatric screening checklists. Strength and difficulty question. Scared, self-report for childhood anxiety-related emotional disorders. Vanderbilt ADHD Diagnostic Rating Scale. Modified Checklist for Autism in Toddlers. Center of Epidemiological Survey Depression Scale. Mood and Feelings Questionnaire Short Version. Standardized screening instruments like Ages and Stages Questionnaires, Brief Infant Toddler. Social and Emotional Assessment, Early Childhood Screening Assessment, Modified Checklist for Autism in Toddlers, Parents' Evaluation of Developmental Status, and Survey of Well-Being of Young Children designed for this age group can be helpful in systematizing the evaluation of common problems. Common behavioral problems in children. Infants' common behavioral problems are abdominal colic, resistance to feeding, stranger anxiety. Children's common behavioral problems are emotional problems, stereotypic movement disorder, elimination disorders like enuresis and encopresis, speech problems, sleep problems. Adolescents' common behavioral problems are eating disorder, sexual problems, delinquency, infant colic. It is a benign or self-limited condition. Even though crying or fussiness is present in all babies, medical attention in about 20%. Diagnostic criteria of infantile colic are an infant who is less than 5 months of age, recurrent and prolonged periods of infant crying, fussing, or irritability which is without obvious cause and not prevented. There should be no failure to thrive, fever, or illness. It is diagnostic with Wessel criteria, that is the rule of 3. Beginning in the 2nd or 3rd week of life. It lasts about 3 hours a day. It occurs 3 days per week. Infantile colic lasts for more than 3 weeks. And it resolves by 3 or 4 months of age. Proposed etiologies of infant colic. The first one is gastrointestinal disturbance and faulty feeding techniques. Underfeeding, overfeeding, infrequent burping, and swallowing air. Cow's milk protein intolerance, allergy. Hydrolysate formulas. Hypoallergenic diet. Lactose intolerance. Gastrointestinal immaturity. Excessive gas is produced when the unabsorbed carbohydrate is fermentation. Intestinal hypermotility and alterations in fecal microflora. Proposed etiologies of infant colic. The first one is biologic causes due to like immature motor regulation. Increased vulnerability to feeding intolerance, increased serotonin level. Tobacco smoke and nicotine exposure. Secondly, psychosocial theories. Colic is a psychosocial phenomenon. Caretaker's perception of what is excessive and prolonged. Temperament, overstimulation, and parental variables. Family stress, maternal anxiety and transmission of tension from mother to infant. Now let us see on clinical features of infantile colic. It is manifested with paroxysmal colic and qualitative differences in coli. Physical characteristics like facial flushing, tense or distended abdomen, drawing up of the legs, clenching of the fingers and tightening of the arms, arching of the back, and the infant will be in a difficulty in consoling and sometimes relief may be noted. Management of infantile colic is to decrease crying and bolster the infant-family relationship and parental support by confirming the diagnosis, reassurance, and advice to take breaks from the crying infant, parental education by telling as the condition is common and usually resolves spontaneously, not caused by something they are doing or not doing, and teaching feeding technique. Soothing techniques are important in colic management, which decreasing sensory stimulation, taking the infant for a ride in the car or a walk, rocking and swinging infant, changing the scenery, infant providing a warm bath, rubbing abdomen, playing an audio tape, providing white noise generators. The above technique can be used in any order or combination, and try a technique for several minutes. Dietary changes in infantile colic are trial of dietary interventions, breastfed infants. Maternal milk product consumption or a hypoallergenic maternal diet. Look for signs of allergy. Option for formula-fed infants with colic. Extensive hydrolysate formula like Alimentum, Nutramigen, Pregestamil. Continued if there is a decrease in fussiness. The response usually occurs within 48 hours. The original formula is resumed if there is no change. Soy protein formula, fiber-enriched formula. Other options for management are using probiotics, from Lactobacillus reuteri. Not for routine management because of the cost of probiotics. Simethicone causes gas bubbles to coalesce, facilitating expulsion. Safe, but it may interact with levothyroxine. Herbal remedies like herbal teas, fennel seed, gripe water. Follow-up is individualized and re-examination to be reassured. Referral for parents who are extremely anxious. Outcomes. Parents of colicky infants experience stress, fatigue, guilt, and depression. Other common childhood behavioral disorder is disruptive, impulse control, and conduct disorders. These are interrelated sets of psychiatric symptoms. They are characterized by a core deficit in self-regulation. Anger, aggression, defiance, and antisocial behaviors. It includes oppositional defiant, intermittent explosive, and conduct problems. Other specified unspecified disruptive impulse control conduct. Antisocial personality disorders. Oppositional defiant disorder. Angry, irritable mood, argumentative defiant behavior, or vindictiveness. Exhibited during interaction with at least one individual. Lasting at least 6 months. For preschool children, it must occur on most days. In school-age children, it must occur at least once a week. Severity is based on the occurrence in the number of setting as mild, moderate, and severe. Etiology and risk factors in oppositional defiant disorder. Number of neurobiological markers, pre, peri, and postnatal insults, reduced basal cortisol reactivity, serotonergic abnormalities, parents of behaviorally disordered children. Negative parenting responses, impaired parent-child attachment, child maltreatment. Family poverty and crime, peer-level influence, and neighborhood influences are common causes of oppositional defiant disorder. Diagnostic criteria for oppositional defiant disorder are: at least 6 months as evidenced by at least 4 symptoms. First, angry or irritable mood like angry temper, often easily annoyed. The second is argumentative or defiant behavior imbite nanet. Actively defies or refuses to comply. Deliberately annoys others. Blames others. Argues. The third, vindictiveness. Spiteful or vindictive or bekelegna. It should be associated with distress or impact negatively. It is not exclusively during a psychotic, substance use, depressive or bipolar disorder. Conduct disorder. Is characterized by a repetitive and persistent pattern. At least 12 months of serious rule-violating behavior. The symptoms of conduct disorder are divided into 4 major categories. Aggression against people and animals. Destruction of property. Deceitfulness or theft. Serious rule violations. 3 subtypes based on the age of onset. Childhood onset type. Adolescent onset type or unspecified type. Based on severity classification, know of symptoms and impacts as mild, moderate, and severe. Clinical course of conduct disorder. The prevalence is approximately 3%. The prevalence rate of conduct disorder is higher in adolescence than in childhood, males. Lower socioeconomic classes. Becomes a concern if it is intense, persistent, and pervasive. Affects the child's social, family, and academic life. The earliest manifestations of oppositionality are stubbornness, defiance, and temper tantrums, argumentativeness. Approximately 65% of children exit from the diagnosis after a 3-year of follow-up. Age at onset is an indicator of prognosis. Approximately 30% with comorbid ADHD. It increases risk for depressive and anxiety disorders. Parent training programs in conduct disorder. Specific parent training programs. Parent-child interaction therapy. Helping non-compliant child. Parent management training. Predictors of non-response to interventions are initial symptom severity. Involvement of parent. Premature termination, less than 5 treatment sessions, is high as 50 to 60%. Predictors of premature termination of parent training programs are the following. The first is single parent. The second is family income. The third is parental education levels. And the fourth is the maternal age. Cognitive behavioral therapy in conduct disorder. Delivered in multiple sessions and multidimensional treatment is needed. School-based behavioral interventions. Youth anger management. Problem-solving training. Family therapy. Psychiatric consultation. Medical management like methylphenidate. The average dose for methylphenidate is approximately 1 mg per kilogram per day. And second medical management is with an atypical antipsychotic like risperidone, which helps in reducing aggression and conduct problems in children aged 5 to 18 years. A usual daily dose of risperidone for severe aggression is 1 to 2 mg for children and 2 to 4 mg for adolescents. The duration of trials is 6 to 8 weeks for atypical antipsychotics. Have strong evidence for the management. Predictors of non-response are higher rule-breaking behavior and the presence of comorbid mood disorders. Squeal in disruptive, impulse control, and conduct disorders are suicidal behavior, physical injury, delinquency and criminality, legal problems, substance use, unplanned pregnancy, social instability and marital failure. Another common childhood behavioral disorder is tantrums. What is tantrums? It is a sudden outburst of anger, frustration, and a bad temper. Physical aggression or resistance manifested with rigid body, biting, kicking, throwing objects, hitting, crying, rolling on the floor, screaming loudly and banging. Common during the first few years of life. Averted by a parent's awareness or attunement to certain cues. Advised that parents plan to be aware of triggers and minimize the trigger. Good. What are breath-holding spells? Reflexive events occur during a tantrum from 6 months to 6 years of age. May lose consciousness and occasionally will have a brief seizure. Parents are best advised to ignore it. It generally disappears without reinforcement. Subtypes of breath-holding spells. Cyanotic, pallid, and mixed episodes. Iron deficiency may be present and it may respond to iron therapy. No increased risk of seizure disorders. Medical conditions should be ruled out. Management. Professional help from the Child Guidance Clinic. Parents should be made aware of the beginning of temper tantrums and when the child loses control. Nobody should make fun of and tease the child. Parents should model the anger control. Parents' anger worsen the problem. Providing choice. Enhancing the parent-child relationship. Building problem-solving skills. Referral for a mental health evaluation needed if not responding to parent coaching or head banging or high levels of aggression. Lying. Why lying? For children 2 to 4 years. A form of fantasy for children or a method of playing with language. To avoid an unpleasant confrontation means not permitting the realization. Rarely malicious or premeditated. Why lying? In older children. Temporary good feeling and to protect against a loss of self-esteem. To avoid a negative consequence for misbehavior. Habitual lying can also be promoted by poor adult modeling. To avoid adults' disapproval. Chronic lying can occur in combination with antisocial behaviors. A sign of underlying psychopathology. Habitual lying can become frustrating for parents. Should be discouraged from making accusations or focusing on catching their child in a lie. Should work toward creating an atmosphere that makes it easier for their child to tell the truth. If a parent is aware that a child took a cookie without permission. I am disappointed that you took the cookie without permission. Reminded of how he can get things that he desires in an acceptable way. Mental health evaluation is indicated. if this behavior cannot be resolved through the parent's understanding of the situation. Stealing. Many children steal something at some point in their lives. It is an impulsive action to acquire something they want, like candy or a toy from the store shelf. Can be an expression of anger. If noticed, it is a teaching opportunity. Frequent stealing may be a response to stressful environmental circumstances. Further exploration and evaluation can be learned from adults. Survival mechanisms like youth living in poverty. It is important for parents to help their children undo the theft. When stealing is part of a pattern of broader conduct problems, referral for a mental health evaluation is warranted. Truancy is a disorganization within the home, caretaking needs of younger siblings, developing conduct problems, or emotional problems. More common in older children. Truancy is never developmentally appropriate. Causes of truancy are learning difficulties, social anxiety, traumatic exposure, peer pressure, substance use. Addressing underlying causes. Empowering family. High risk for substance abuse, unsafe sexual activity, and other risk-taking behaviors. It is never developmentally appropriate and should be referred. Habits. It involves repeated actions or patterns of behavior. Common in childhood and range from usually benign and transient behaviors to a more problematic. In DSM-5, habits are not included as a diagnostic category. Not viewed as disorders causing clinically significant distress or impairment. Examples of common habit disorders from benign like thumb-sucking and nail-biting and problematic as bruxism and trichotillomania. Thumb-sucking. Thumb-sucking is common in infancy and beyond 5 years may be associated with a squeal-like abnormality of teeth as shown in the picture. Difficulty in mastication and swallowing. Deformity of thumb. Facial distortion. Speech difficulties with consonants and gastrointestinal tract infections. Management of thumb sucking includes support and to be advised. Distraction. Simple reminders and reinforcers. Mechanical devices. Consultation. Hygienic measures. Praising and encouraging the child, and parents need to be reassured about the habit. Bruxism. Teeth grinding is common. It is a habit in 5 to 30% of children. Can begin in the first 5 years of life. It is associated with daytime anxiety. Persistent bruxism can manifest as muscular or temporomandibular joint pain, dental occlusion. It is associated with anxiety. Reduce anxiety might relieve the problem. Relaxing by reading or talking or allowing for discussion and praise and other emotional support is needed. Persistent bruxism requires a referral. Tics. It is a brief, sudden, rapid repetitive movements of striated muscles. Mainly of the face and neck. It is the outlet of suppressed anger and worries for control of aggression. Characterized by multiple motor tics and vocal tics. Examples of motor tics are eye blinking, grimacing, shrugging shoulder, tongue. The protrusion and facial gesture. Examples of vocal tics are throat clearing, coughing, barking, sniffing. Self-stimulating behavior in response to tension and anxiety. Often in school children. It may occur in deep sleep. Enuresis. Repetitive involuntary passage of urine at inappropriate places, especially in bed. Beyond the age of 4 to 5 years, and it occurs in 3 to 10% of school children. And diagnosed if it occurs twice weekly for at least 3 months. At age of 5 years, 7% of males and 3% of females have enuresis. Enuresis is classified as persistent or primary, regressive or secondary. Enuresis causes are physiological, bladder capacity, psychological, deep sleep, small bladder capacity, psychological, dominant parent or punishment, sibling rivalry, toilet distance from the bedroom, the hostile or dependent parent-child relationship, Emotional deprivation due to insecurity and parental death. Dark passage to the toilet or cold or fear of toilets. Organic spinal bifida, neurologic bladder, juvenile DM, seizure disorders. Monosymptomatic enuresis and non-monosymptomatic enuresis. Management of enuresis. Behavioral therapy. Environmental modification. Restriction of fluid after dinner. Voiding before bedtime. Interruption of sleep before the expected time of bedwetting. Fully waken up by the parent and made aware of the passing of urine at night. Give a responsibility for changing the bedcloths. Encourage and reward the child for dry nights. Bladder exercise and electric alarm bell device and safest method. Punishment and criticism may lead to embarrassment. Pharmacologic like tricyclic antidepressant, imipramine can be used. Encopresis. Voluntary or involuntary passage of feces into inappropriate places. At least once per month for 3 consecutive months once a chronologic age of 4 years. Subtypes of encopresis are: retentive encopresis, with constipation and overflow incontinence which represents 65 to 95%. Non-retentive encopresis is without constipation and overflow incontinence. Primary or secondary. Associated problems in encopresis are chronic constipation, parental overconcern, overaggressive toilet training, toilet fear. Attention deficit disorders, poor school attendance and learning difficulties can occur. Management of encopresis. Behavioral techniques. Regular bowel habits and training. Dietary intake. Parental support. Medical management. Impaction and anal fissures. Psychologist. Child and parents. Reassurance and counseling. Attention deficit disorders. A syndrome with 2 categories of core symptoms, inattention and hyperactivity impulsivity. Predisposing factors are birth complication, dietary influences, iron and zinc deficiency. Drug exposure and lead poisoning, structural and functional differences, interaction between genetic and psychosocial factors. For children 17 years needs greater than or equal to 6 symptoms. For adolescents greater than or equal to 17 years and adults need greater than or equal to 5 symptoms. Affect cognitive, academic, behavioral, emotional, and social functioning. Symptoms of inattention are: failure to provide close attention to detail. Difficulty maintaining attention in play, school, or home activities. Seems not to listen. Fails to follow through. Difficulty organizing tasks, activities, and belongings. Avoids tasks that require consistent mental effort. Loses objects required for tasks or activities. Easily distracted by irrelevant stimuli and forgetfulness in routine activities are symptoms of inattention. From symptoms of hyperactivity and impulsivity. The first is difficulty remaining seated when sitting. Excessive fidgetiness. Feelings of restlessness or inappropriate running. Difficulty playing quietly. Difficult to keep up with, seeming to always be on the go. Excessive talking. Difficulty waiting for turns. Blurting out answers too quickly and interruption or intrusion of others. The subtype of ADHD in a given patient can change from one to another over time. Predominantly inattentive. Symptoms of inattention. Predominantly hyperactive impulsive. Symptoms of hyperactivity impulsivity. Combined. Symptoms of inattention and hyperactivity impulsivity. Management in ADHD is classified depending upon the predominant symptoms. Management is done by a team approach. Pharmacological like stimulants. Drug holiday. Non-pharmacological. Behavioral therapy. Behavior modification, counseling, and guidance of parents. Appropriate training and education of the child. Cognitive behavioral therapy and biofeedback. Communication disorder. Communication requires the interaction of an intact mechanism. Hearing sensitivity, perception, intelligence, structural integrity, motor skill and emotional stability. Children learn a language in early childhood and later they use language to learn. Developmental language disorder. Impairment in the ability to receive, send, process, and comprehend concepts or verbal, nonverbal, and graphic symbol systems. Most common developmental disability of childhood. Occurring in 5 to 10% of children. Increased risk for difficulty with reading and written language. Often persist through adolescence or adulthood. Early intervention minimizes more serious consequences. Speech disorder. Articulation disorder. The ability to produce speech sounds increases with age. Most children with disordered articulation and phonology do not exhibit the identifiable physical reason for the problem. Fluency disorder, stuttering. Interruption in the flow of speaking due to atypical rate, rhythm, and repetitions. It begins between the age of 2 to 5 years and is more common in males. The etiology of stuttering is not completely understood. It can be developmental, acquired, and psychological. Inability to adjust to the environment and emotional stress. Voice disorder. Vocal quality, pitch, loudness, resonance, or duration. Hearing impairment. Have difficulty with all parameters of speech, not just articulation. The result of a limited ability to hear others and monitor their own speech production. Neurologic problems like dysarthria, caused by neuromuscular impairment. Inability in handling secretions, regurgitation, and recurrent upper respiratory tract infection and pneumonia. Apraxia. An impairment in the ability to program the speech musculature to select, plan, organize, and initiate a motor pattern. It is presumed to be neurologic in origin. The validity of considering developmental apraxia of speech or developmental verbal dyspraxia as a separate diagnostic category is one of the most controversial issues in clinical speech pathology. Language disorders. Impaired comprehension or use of spoken, written, or symbol systems. It is characterized by persistent difficulties in the acquisition and use of language. Expressive or receptive. Deficits in comprehension or production. Spoken, written, and sign language. Reduced vocabulary, limited sentence structure, and impairments in discourse. Resulting in functional limitations in effective communication, social participation, academic achievement, occupational performance. School phobia. It is a fear of going to school. Emotional disorder of children who are afraid to leave the parents. Symptoms of crisis situation of developmental stages. They has a recurrent compliant like abdominal pain, headache. Subsidies if allowed to remain at home. Contributing factors for school phobia. Anxiety. Intellectual disability. School environment. Management. Improve school environment. Play sessions and recreational activities. Family counseling. Assesses health status. Eating disorders. Overvaluation of a thin body and dysfunctional weight control behaviors. Usually affecting white and adolescent females. Persistent disturbance in eating include anorexia nervosa. Avoidant restrictive food intake disorder. Binge eating disorder bulimia nervosa. Pica. Rumination disorder. Screening for eating disorder using SCOFF, which consists of 5 clinician-administered questions. Do you make yourself sick because you feel uncomfortably full? Do you worry you have lost control over how much you eat? Have you recently lost more than 1 stone, 14 pounds or 6.35 kilogram, in a 3-month period? Do you believe yourself to be fat when others say you are too thin? Would you say that food dominates your life? A yes to 2 or more questions was associated with the sensitivity and specificity of 187.5% for the diagnosis of an eating disorder respectively. Anorexia nervosa. Refusal of food to maintain normal body weight by reducing food intake, especially fats and Carbohydrates. They practice vigorous exercises for weight reduction or induce vomiting by stimulating the gag reflex to maintain slim. Involves significant overestimation of body size and shape, with a relentless pursuit of thinness. Restrictive subtype. Combines excessive dieting and compulsive exercising. Binge purge subtype. Overeat and vomiting or taking laxatives. No specific cause for anorexia nervosa. Anorectic parents and conflict in a relationship. They may have associated conditions like the disease of liver, kidney, heart, or diabetes. Parents of the affected adolescent may be anorectic and have conflict in their relationship with the child or overprotective, which leads to the development of immaturity, isolation, and excessive dependence. Diagnostic criteria for anorexia nervosa. First is significantly low body weight in the context of age, sex, developmental trajectory, and physical health. Second is intense fear of gaining weight or of becoming fat, or persistent behavior. The third is disturbance in which one's body weight or shape is experienced, undue influence of body weight or shape on self-evaluation, or persistent lack of recognition of the seriousness of current low body weight. Specifier is as in partial remission or in full remission. Specify the severity by BMI as mild, BMI greater than or equal to 17 kg/m². Moderate, BMI is between 16 to 16.99 kg/m². Severe when the BMI is between 15 to 15.99 kg/m². Avoidant or restrictive food intake disorder. Lack of interest in food, the sensory characteristics of food, or a conditioned negative response associated with food intake. The eating behavior leads to a persistent failure to meet nutritional or energy needs. Manifested by at least one of the following: clinically significant weight loss, or in children, poor growth, or failure to achieve expected weight gain, nutritional deficiency, supplementary enteral feeding or oral nutritional supplements are required to provide adequate intake, impaired psychosocial functioning. Not due to a lack of available food or associated with a cultural practice. Does not occur solely in the course of anorexia nervosa or bulimia nervosa. Binge eating. Binge eating episodes are marked by at least 3 of the following. First, rapidly then normal. Second, until feeling uncomfortably full. The third is eating large amounts of food when not feeling physically hungry. Fourth, eating alone because of embarrassment by the amount of food consumed, and the fifth is feeling disgusted with oneself, depressed, or guilty after overeating. Binge eating episodes occur on average at least once a week for 3 months, and no regular use of inappropriate compensatory behaviors, like purging, fasting, or excessive exercise, as are seen in bulimia nervosa. Binge eating does not occur solely during the course of bulimia nervosa or anorexia nervosa. Binge eating severity is based upon the number of binge eating episodes per week, as mild is 1 to 3 episodes per week. Moderate from 4 to 7 per week. Severe 8 to 13 per week, and extreme 14 or more episodes per week. Pica. Repeated eating of non-food substances for at least 1 month. Some common pica are geophagia, pagophagia, xylophagia, trichophagia, urophagia, and coprophagia. It may be due to parental neglect, poor attention of a caregiver. Nutritional deficiency. It is common in poor socioeconomic families, malnourished children, and mentally subnormal. Both sex equally. Resolves spontaneously unless mentally disabled. Rumination disorder. Repeated regurgitation and rechewing and re-swallowing for at least 1 month. Not due to a general medical condition or during the course of eating disorders. Occur between 3 to 12 months and is common in males. A behavioral intervention like lemon in juice and drugs. Management of the eating disorder are: advice on irrelevant to weight loss, not to blame parents for eating disorders, reinforcement of parents, dialectical behavioral therapy in which distorted thoughts and emotional responses are challenged, analyzed, and replaced with healthier ones, with an emphasis on mindfulness, which requires adult thinking skills and is useful for older patients either in group therapy or combining patients at various levels of recovery. Recommendation: diagnose common behavioral problems in children. Start management early. Referral to psychiatric specialty clinic accordingly. And finally, I recommend researcher to conduct a study on common behavioral disorders in children's magnitude and associated factors with it. These are the reference I used for the presentation. Thank you to attend the session and don't forget to subscribe and like the channel.